Alors, bonjour à tous. Je m'appelle Lise Gauvin. Je suis responsable du carrefour de l'innovation et de l'évaluation en santé du Centre de recherche du CHUM. Et aujourd'hui, on a le plaisir d'avoir un séminaire de recrutement qui nous sera donné par la docteure Drudi. La présentation est intitulée « Le patient vulnérable, une approche multidisciplinaire en chirurgie vasculaire ». J'informe toutes les personnes qui participent que nous sommes en train d'enregistrer la présentation pour celles et ceux qui devraient quitter, qui pourraient vouloir quitter avant le temps pour d'autres rencontres. Et si vous êtes intéressé à écouter la présentation, elle sera disponible sur la page YouTube du centre de recherche quelques jours après la présentation. Et Rachel Bouchard, celle qui vous a envoyé le lien web, pourra vous faire parvenir le lien pour y accéder. Alors, l'objectif d'un séminaire de recrutement, c'est de permettre aux chercheurs du centre et du centre de recherche et du CHUM de mieux connaître la personne qui souhaite se joindre au centre de recherche et elle va présenter qui elle est, d'où elle vient et quelle est la programmation de recherche qu'elle propose. Pour information, et vous avez eu une petite description des réalisations de Laura, et bien qu'elle soit en début de carrière, il y en a déjà plusieurs. J'en mentionne que deux et je vais lui laisser le plaisir de partager le reste. Alors, Dr. Drudi a obtenu un diplôme d'études spatiales à l'Université internationale de l'espace et elle a contribué à plusieurs projets de recherche clinique en collaboration avec l'Agence spatiale canadienne et la NASA. Elle dirige une plateforme spécialisée en recherche concernant... Pardon? Est-ce qu'il y a quelqu'un qui a voulu dire quelque chose? J'ai entendu une voix. Alors, elle dirige donc une plateforme spécialisée en recherche concernant l'évaluation de la fragilité et de la vulnérabilité des patients atteints d'une maladie vasculaire. Et actuellement, elle est en Europe en train de finaliser son fellow et elle va rentrer au CHUM à compter de l'été 2021 et elle va être au service de chirurgie vasculaire. Alors, sans plus tarder, je vais céder la parole à Laura. Il y aura la possibilité de poser des questions à Laura à la fin de sa présentation, qu'elle pense va durer une trentaine de minutes. Et vous pourrez poser les questions soit dans le clavardage, le chat, ou vous pourrez, puisqu'on est un groupe relativement petit, vous pourrez les poser directement verbalement. Alors, faites juste signe que vous avez une question à poser. Alors, Laura, sans plus tarder, je vais te céder la parole, mais je vais demander aux gens de mettre leur micro en sourdine pour permettre, pour pas qu'on entende des bruits d'arrière-plan. Voilà.
Magnifique. Merci bien. Alors, bon après-midi. C'est avec grand plaisir lors de ce séminaire de recrutement de me présenter, d'expliquer les projets de recherche que j'ai faits lors de ma formation et les projets de recherche que je ferai lorsque je commencerai à travailler au sein du CHUM. Avant de commencer, je tiens à remercier Lise Gauvin, Alain Rivard et Rachel Bouchard pour avoir organisé ce séminaire. Aujourd'hui, je parlerai du patient vulnérable en chirurgie vasculaire employant une approche multidisciplinaire. Mon présentation sera initialement en français et je passerai à l'anglais lorsque j'expliquerai les projets de recherche que j'ai faits, effectués et à venir. Je n'ai aucun conflit d'intérêt. Et voici mes formations. En 2011, j'ai obtenu un diplôme des études spatiales en Autriche et j'ai donc complété mon doctorat de médecine à l'Université de McGill et j'ai ensuite poursuivi une résidence en chirurgie vasculaire au sein de la même université. Et pendant mon résidence en chirurgie vasculaire, j'ai complété une maîtrise en épidémiologie, biostatistique et santé de travail à l'Université de McGill. Et présentement, je poursuis un fellowship en chirurgie endovasculaire périphérique avancée à l'hôpital Sint Blasius de Dendermonde en Belgique, un des leaders européens en ce qui concerne les chirurgies endovasculaires périphériques. Alors, mes intérêts pour la fragilité ou frailty et la vulnérabilité a sans doute commencé avec mes projets de recherche et collaboration en médecine aérospatiale. De 2008 à 2013, j'ai participé activement à des projets de recherche financés par la NASA, l'Agence spatiale canadienne et l'Agence spatiale européenne. Mes projets de recherche se sont principalement concentrés sur l'altération de la physiologie des astronautes, cosmonautes et taïkonautes à bord des vols spatiaux et à bord de la Station spatiale internationale. Et ces projets ont concentré sur la sarcopénie, ostéopénie, le processus inflammatoire et la régulation immunitaire, qui sont tous des problématiques communes avec le syndrome de fragilité ou frailty. Je me suis aussi engagée dans des projets de télémédecine en utilisant des plateformes de télémédecine pour des populations éloignées du monde, comme en Antarctique, aux stations McMurdo, comme avec des populations isolées et donc vulnérables. Et au cours de ma formation en médecine, j'ai eu l'occasion de pratiquer la médecine de famille à Mistissini dans une municipalité de la baie James. Et c'était ici, à Mistissini, c'était ma première expérience clinique confrontant des énormes vulnérabilités sociales ainsi que des disparités dans les soins de santé qui affectent pas seulement cette population CRI à Mistissini, mais l'ensemble des populations autochtones. Et tout au long, après ces rencontres émouvantes et révélatrices, mon éditorial sur ces expériences à Mistissini a été publié dans le journal de CMAJ. Et tout au long de ma résidence, j'ai vu à maintes reprises les disparités dans les soins de santé, les traitements et les résultats cliniques qui touchent ces populations vulnérables, beaucoup d'entre elles ayant une maladie vasculaire dans une phase terminale. Et avant de participer à des projets de recherche pendant ma résidence, je savais que je voulais poursuivre des études en épidémiologie pour mieux comprendre ma passion qui est la recherche. Suite à une présentation sur la fragilité ou frailty en cardiologie et chirurgie cardiaque par le Dr. Jonathan Afilalou, je savais que je voulais être encadrée par un chercheur clinicien chevronné. Et je voulais travailler sur la fragilité ou frailty en chirurgie vasculaire, qui était à l'époque un sujet émergent. J'ai eu le privilège d'être acceptée dans le programme d'épidémiologie financé par l'Institut de recherche en santé du Canada et les fonds de recherche Santé Québec. Et pour mes projets proposés sous le mentorat de Dr. Jonathan Afilalou. Les objectifs de ces projets était d'identifier l'utile de fragilité le plus prognostique permettant de prédire l'évolution clinique chez les patients atteints d'une maladie artérielle périphérique. Et d'identifier également de nouveaux éléments prédicteurs de fragilité chez les patients subissant des procédures vasculaires comme l'aire du muscle psoas. Et finalement, pour identifier certaines composantes du syndrome de fragilité gériatrique et leur impact sur les résultats cliniques chez les patients en chirurgie vasculaire. Et en même temps que je poursuivais les recherches en chirurgie vasculaire avec ces études prospectives, je participais également à plusieurs analyses ad hoc dans les grands registres de chirurgie cardiaque et cardiologie avec Dr. Jonathan Afilalou. Deux de ces projets étaient publiés en JAMA Cardiology et JACC, et on observait et regardait les effets de la santé mentale comme la dépression sur la mortalité chez les patients qui subissaient des chirurgies en chirurgie cardiaque et cardiologie, et aussi regardait plusieurs interactions entre différents facteurs de risque et la fragilité dans la même population. Je vais maintenant passer à l'anglais pour expliquer les projets de recherche que j'ai faits spécifiquement en chirurgie vasculaire et les projets proposés pour mon plateforme de recherche. So switching gears now, most of my projects and research has really been focused on frailty and really operative risk prediction. And as most of you know, operative risk prediction is central to decision-making in surgery. However, current tools and scores really only provide a snapshot in time of a patient's health status that is heavily focused on comorbidities. These tools tell us very little about a patient's physiologic reserves that might be called upon at a time of stress, such as surgery. So risk prediction is moving towards frailty risk models. Now, frailty, how we define it and how we measure it, isn't straightforward. And at the very simplest, can be described as a multidimensional syndrome characterized by a decline in physiologic reserves. Now, there are several different domains of frailty given this multidimensional framework, and as we grow more to learn about frailty, more of these spheres get added. But one of the spheres is certainly a comorbid state. We can have cognitive deficits, functional impairment that can incorporate sarcopenia, physical deficits, mood disorders like depression, anxiety, and most recently, PTSD or post-traumatic stress disorder. A lack of social support, such as social isolation, which heralds in this concept of social vulnerability, and undernutrition and malnutrition separately. These are two separate concepts when we speak about nutrition. So given the heterogeneity in the literature about frailty and how we evaluate it, our group sought to perform a scoping review and to describe the current state of knowledge of the impact of frailty on perioperative clinical outcomes in patients undergoing vascular interventions. And what we found was astounding. Amongst the 23 studies that were published prior to 2019, we found that there were 14 different scales of frailty to evaluate vascular surgery patients amongst 23 studies, showing a clear lack of consensus on what the ideal tool is to evaluate frailty in this patient population. And moreover, there were 3 different frailty definitions and models that people used. The most common model is an accumulation of deficits model, which essentially is the more deficits you have, the more frail you are. And most of the frailty tools fall into this category. For those who are versed with the frailty literature, the Edmonton Frail Scale, the Clinical Frailty Scale, and the Frailty Index falls under this category. There's also a frailty phenotype, which has been heavily described and validated by Fried and his colleagues, which essentially incorporates physical performance to assess frailty. So a gait speed, 5-meter walk test, grip strength, and it also includes weight loss. And finally, there are novel and emerging frailty markers, surrogates, and biomarkers that people are exploring the last 5 years, specifically low psoas muscle area, sarcopenia, albumin or hypoalbuminemia, and anemia. And this certainly can be incorporated into the frailty phenotype. And finally, the study also demonstrated that frailty, like many other studies have shown, was associated with increased 30-day and all-cause mortality, increased complications, infection rates, adverse functional outcomes, including major adverse cardiovascular events and major adverse limb events, such as amputation. So given the heterogeneity in this literature, this really was the basis for my master's project. The prospective study for my master's project was entitled the FRAILED Study, Frailty Assessment in Lower Extremity Arterial Disease, to find the best frailty tool for patients specifically with peripheral arterial disease. And I was very intentional about my patient population. Most frailty tools incorporate physical performance. However, for patients with peripheral arterial disease, such as claudication and critical limb-threatening ischemia, who cannot perform these physically based tests, such as the gait speed or 5-meter walk test, I wanted to choose an appropriate tool for this patient population. So I did a head-to-head comparison of 6 non-physical performance-based scales to predict poor outcomes following interventions for peripheral arterial disease. Our primary endpoint was a composite of all-cause mortality and worsening disability at 12 months, which we defined as 2 or more accrued disabilities as measured by ADLs, IADLs, or institutionalization. And to just give you a quick overview of what these frailty tools are and how we measure them, you can sort of understand with this table the heterogeneity amongst the frailty tools. The frailty tools here are in this column. We have the Edmonton Frailty Scale, the Groningen Frailty Indicator, the Essential Frailty Tool Set, which was developed by Afalalo and his colleagues, the Frailty Index, the Multidimensional Prognostic Index, and the Risk Analysis Index, which was most recently validated in a surgical cohort. And we can see here that these frailty tools are very heterogeneous in terms of what they incorporate from the frailty domain, from comorbid state, cognitive deficits, mental health disorders, social vulnerabilities and isolation, malnutrition, subjective weakness, hearing and visual impairments, polypharmacy, and the last column is anemia. And interestingly enough, the most common tool cited in the literature in medicine and surgery is the frailty index, which incorporates only one aspect of the frailty syndrome, a comorbid state, which arguably isn't a good tool or appropriate tool for frailty, but it's the easiest to do, especially retrospectively, because all you have to do is incorporate someone's comorbid state. But to actually perform an appropriate frailty assessment, arguably the only way in this day and age is to do a prospective study to gather a lot of the different domains that might not be captured in a retrospective fashion. So moving forward, here we have, again, our frailty cohort that comprised of 180 patients, and you can see for our endpoint of mortality and worsening disability, which is the red bar, the prevalence of frailty varies across all the tools from 17 to 73%, obviously showing the heterogeneity across all of these tools that should be measuring frailty. And when we compare in a head-to-head fashion using multivariable logistic regression and model performance statistics, you can see that the two scores that really rose to the top in this patient population is the Groningen Frailty Indicator and the Essential Frailty Toolset. I won't belabor all the statistics in this graph, but just to say, when we perform model prediction statistics, we're using the Bayesian information criterion. And essentially the rule of thumb for the BIC is that the lower the number, the better the model. And here we see that the GFI and the Essential Frailty Toolset had lower numbers, and the IDI measures the statistical significance between this model and the baseline model. So essentially, we found and we recommend for patients with peripheral arterial disease, the Essential Frailty Toolset and the Groningen Frailty Indicator should be used to evaluate frailty, especially when we're looking at mortality and worsening disability. These two scores are very different. The Groningen Frailty Indicator is a very labor-intensive frailty tool to administer. The Essential Frailty Toolset, developed by Aflalo and his colleagues in a cardiology population, is very user-friendly, only incorporates 5 different domains. There's an app for it, and it was really utilized to actually be incorporated into clinical practice and have clinical applicability. So we recommend both of these tools. However, many of these studies will have to be, again, validated in a larger cohort, since this was a pilot study only involving 180 patients. This frailed cohort was also looking at several different components of a geriatric and frailty, I guess, syndrome. And we looked at depression and malnutrition separately as independent predictors for our outcomes of mortality, disability, and even complications. And both of those have been submitted for peer review. I won't go into the details of these studies, but just to say that these studies have been done and will hopefully be published in the near future. Switching gears and talking about novel biomarkers. This one, psoas muscle area, has been published time and time again over the past 5 to 10 years in medicine and surgery. We were the first to show psoas muscle area and the predictive value of psoas muscle area in patients who are undergoing abdominal aortic aneurysm repairs. Our group demonstrated using Core Slicer, which is a semi-automated program freely available on the internet, that you can measure psoas muscle area in a very easy way, under 30 seconds. And can also actually measure fat for those who are looking into the concept of sarcopenic obesity. And essentially, we did a retrospective review on patients undergoing abdominal aortic aneurysm repairs, both open and endovascular surgeries, and stratified them based on psoas muscle area. So we stratified our cohort into low, medium, and high psoas muscle area. And you can see on this Kaplan-Meier survival curve, with days following intervention on the x-axis and the probability of survival on the y-axis, that those with the lowest psoas muscle area had a decreased probability of survival following their intervention. This has been replicated in several other studies, some on open AAAs purely, some on endovascular, abdominal aortic aneurysm repairs, and some with complex branched and fenestrated endovascular repairs. Of course, this is an unadjusted Kaplan-Meier survival curve, but when we perform our Cox proportional hazards regression model and adjust for age, sex, body mass index, the revised cardiac risk index, which is a tool we use in the pre-op clinic to assess adverse outcomes following surgery, an endovascular versus open approach, and total psoas muscle area. And we see that psoas muscle area was an independent predictor of our outcome, all-cause mortality. And essentially we see here, and this is really the take-home message, that there was a 14% reduction in all-cause mortality for every 1 centimeter squared increase in psoas muscle area. So meaning the more psoas muscle area you have, the less likely you are to have an adverse consequence like a death following surgery, particularly surgery for open or endovascular AAAs. So I certainly have several ongoing projects. I'm trying to finish all the projects that I did with the Frailty Research Group at the Jewish General Hospital under the mentorship of Dr. Jonathan Aflalo. And of course, I'm already engaging in research projects here in Belgium. So Belgium, especially here at ASI St. Blasius, is one of the highest clinical volume centers for what concerns peripheral endovascular techniques and surgeries. And it's really a hub to assess novel technologies for complex lesions in the peripheral arterial tree. So in peripheral arterial disease, for those who don't know, we can grade lesions using a task classification. And essentially, the more complex the lesions, the higher the tasks. So the task C and D lesions are the most complex. And right now in a Taint trial that is actually finished recruitment, and now in the analysis phase, we're looking at combined drug-coated balloons and drug-eluting technologies and how that can impact limb salvage and patency. So that's ongoing and will obviously be complete by the end of the year. And finally, I'm recently starting a project looking at one aspect of vulnerability, and I will go into detail on what that means. We're looking at gender and racial disparities and outcomes as it pertains to limb salvage in patients with critical limb-threatening ischemia. I'm doing this under the mentorship of Dr. Joe Mills, one of the leaders in limb salvage in the US at the Baylor College of Medicine, and we're doing a retrospective review looking at using the NISBOOK database. So those projects are ongoing. And this really leads in and ties into what I hope to do at the SHUM and the CERF-SHUM. So here are my research platforms. I really have 3 pillars that I'm going to be proposing to you all today. And I'm really going to be focusing on the first pillar, which is really an extension of the work that I have done addressing frailty and vulnerability in vascular surgery. And for those who don't know the complexity of vascular surgery patients and what we do as vascular specialists, we deal with a variety of pathologies, arterial, venous, and lymphatic. And even within the arterial pathologies, we deal with patients with cerebral vascular disease who suffer strokes. We deal with aneurysm pathologies in the entire arterial tree, and we also deal with peripheral arterial disease, which is my specialty. And finally, I'm one of the leaders and members of the Society for Vascular Surgery Wellness Task Force. We created this group in 2017, and I've done ongoing research as it pertains to wellness and burnout within our membership, and something I hope to translate to an organizational level here at the SHUM. And finally, and most recently, have been invited to participate in the Society for Vascular Surgery Diversity, Equity, and Inclusion Task Force, and will comment briefly on that towards the end of my presentation. So what is vulnerability? You would be surprised at how many manuscripts I have read in medicine that use frailty and vulnerability interchangeably and synonymously, and they are 2 separate concepts. I found no standard definition in the medical literature on how one should even define vulnerability. And even though frailty is a component of vulnerability, meaning frail patients are vulnerable, it's certainly not the only component, since not all vulnerable patients are frail. And it doesn't take too much to look outside of the discipline of medicine to find an appropriate definition for vulnerability. And the best definition I found was really in disaster and crisis management, in ecologic and even economic manuscripts. So here's how I'm defining vulnerability, and I'm sure it's going to be a concept that we can grow even more as I do more research in the area. So vulnerability is really diminished capacity of an individual or even a group or community to anticipate, cope, resist, and recover from an impact of a stressor, like a major surgery. There are a variety of factors that can affect vulnerability. There are physical and patient-centered factors. There are economic factors, social factors, and even political factors that can all be incorporated into this concept of vulnerability and certainly provide a lot of barriers to people, individuals, and communities. So what makes a patient vulnerable? Well, the way I see vulnerability, there are certain people that differ in their exposure to risk and certainly how they can cope and have resilience to a stressor like a surgery. So in terms of exposures to risk, there are several gender disparities. You'd be surprised, even in this day and age, that we still don't have clear-cut answers and evidence on how gender can impact outcomes following a vascular intervention. There are a variety of racial and ethnic disparities that can certainly impact outcomes such as limb salvage and any outcomes such as quality of life and even mortality. There are a variety of socioeconomic factors that we can incorporate. This is a huge one and one that's not easily measurable, at least in the medical literature. And I hope to better define that and how to evaluate that using the expertise of a variety of social and economic expertise. And finally, of course, a frail state can impact someone's outcomes. And that's certainly my area and what I've been doing a lot of research in the past few years and hope to build upon that, addressing vulnerability. So I really have 3 specific aims that I'd like to propose in terms of platforms for research that really will be the basis for my entire professional career. It's going to be very hard to tackle, but a challenge worth pursuing. So the first is really to identify biopsychosocial determinants of not only frailty, but vulnerability in vascular surgery and the complex surgical population. There's no one-size-fits-all in vascular surgery. We deal with a very complex patient population, like I said, from cerebral vascular disease, aortic pathology such as aneurysms, and peripheral arterial disease. And you would certainly have to stratify these determinants based on those pathologies. I propose to do a lot of retrospective reviews, hopefully with NISQUIP databases, vascular quality initiative databases, and even large registries, hoping that they would be granular enough to identify some of these biopsychosocial determinants, and of course pursue prospective studies evaluating this. And also to perform, like I said and suggested, subgroup analyses identifying these vulnerable populations from gender disparities, especially with my passion of the huge disparities that I saw in Indigenous populations in Northern Quebec, stratifying based on Indigenous versus non-Indigenous, and even more so, people living on reserves versus those not living on reserves. People who are socially isolated. A lot of our geriatric populations are socially isolated and vulnerable patients on top of all the other vulnerabilities that they may have. And finally, socioeconomic status, which is a huge one to tackle given there are not, at least from the literature that I've read, no easy way to measure it. And of course, it's not enough, in my mind, to identify problems, but using what we've gathered and how are we going to improve these issues. So I would propose to perform pilot interventional studies to address these determinants of vulnerability and how are we going to decrease these risks and exposures and improve resilience in these individuals and communities. There are a variety of implementation strategies that I've been thinking about and brainstorming depending on the vulnerability that we will be addressing. Certainly trying to decrease or modify exposure or even frail states. Frailty is a very interesting one since frailty isn't static, it's dynamic, and performing implementation and interventional strategies to decrease and potentially even reverse frailty using rehabilitation protocols certainly is something worth pursuing. Tackling social isolation using telemedical technologies that have been around since we put people into space, and it took a pandemic for us to actually incorporate this into our practice. So how can we use these technologies to have increased access to care for the people who need it the most? How do we increase resilience in these communities and populations? And I think that would be a very difficult one to address, given many of these vulnerable populations, such as those living on reserves or indigenous populations, they don't trust easily. And how can we incorporate some organizational infrastructural changes that can improve their access to care and improve outcomes, not only within vascular surgery, but across the medical literature and specialty. So this certainly is going to be a huge feat. There's going to be numerous disciplines, in my mind, that are going to be incorporated throughout the trajectory of this work. There's going to be surgeons, there's going to be preoperative care physicians, whoever they may be, from internists to family physicians, nurses, primary care providers who take care of community dwelling individuals, geriatricians who have pioneered frailty work and who will continue to play a very important role moving forward. Psychiatrists and psychologists are crucial when we tackle the mood disorders and how can we decrease some of the impact depression, anxiety, and PTSD have on our outcomes. Social workers, nutritionists and dietitians, physical therapists and occupational therapists. And when we are dealing with indigenous populations, these are very close communities who are really centered around the family structure and elders, and how can we incorporate them and engage them within the work that we're going to be doing to improve their care. And of course, given the huge political barriers that can impact vulnerability, how can we engage politicians in some of this reform? So I've had numerous opportunities to collaborate with people across the world. I'm a team player, master collaborator, and I truly believe that teamwork makes the dream work. So I have some mentors at UCSF, Baylor College of Medicine, Stanford, obviously McGill, U of T, and Michigan Surgery, who I've been working on in a variety of aspects of frailty and vulnerability, and who have already been engaging me to pursue some multi-institutional collaborations as it pertains to this, and they will be crucial moving forward when we pursue some of this multi-institutional work on vulnerability. And finally, the two last slides that are my two pillars and my two last pillars of the research platforms that I would like to propose. For the Society for Vascular Surgery, like I said, in 2017, the SBS was tasked to address wellness and burnout in vascular surgery, given the high rates of burnout, depression, and suicidal ideations within the membership, and to actually increase retention of the workforce. In 2017 and 2018, we evaluated the prevalence and predictors of burnout and suicidal ideations within our membership. And most recently, at the SBS Vascular Annual Meeting that was virtual this past June, I presented the gender disparities between the prevalence and predictors of burnout and suicidal ideations. And it was astonishing to see that female vascular surgeons had an overall 13% risk of suicidal ideations compared to only 4% of men. And how we are moving forward with that are addressing peer support and to actually have small groups addressing this specifically in women. But of course, there are other efforts within the SBS to address prevalence of burnout, such as ergonomic efforts, peer support, like I said, and of course, cultural change. And this is something I really hope to be a leader in and sort of translate to an organizational infrastructure at the CHUM and CHUM, because this not only affects vascular surgeons, this affects the entire community. And how can we create that cultural change locally? And finally, and most recently, the SBS had created a year ago the Diversity, Equity, and Inclusion Task Force. And it really gained a lot of traction after the Med Bikini campaign that took social media by storm a couple of months ago. And essentially, the whole purpose of the DEI is really to evaluate the inequities in vascular surgery career trajectory, such as those associated with sex, gender, race, ethnicity, and age, and to develop proposals for DEI projects, and to obviously use this DEI initiatives and assist the SBS in developing an overarching strategy to increase awareness about inequities, including tools to encourage diversity in the specialty. This is truly something close to my heart. There are not that many women in surgery, let alone vascular surgery. It's still a male-dominated field. How can we encourage equity and diversity within our membership and increase retention of female surgeons? And that's, again, something very easily translatable to an organizational infrastructure like at the SHIM to increase the presence and diversity and equity of all those within surgery and medicine. So I have one more slide, and bear with me, this is my last one. Throughout this presentation, I've spoken a lot about space medicine, frailty, vulnerability, and I hope you got a good sense of who I am as a person, physician, and surgeon. And I can't stress this enough, I would not be here before you today without the incredible mentorship and sponsorship I have received throughout my educational career. And you know, Isaac Newton really said it best. If I have seen further, it is by standing on the shoulder of giants. And I am standing on many. And I would really like to thank the Division of Vascular Surgery and the Department of Surgery at the SHIM for A, recruiting me, believing and trusting in me, and supporting the vision that I have, not only for the SHIM, but truly for a program that I think will benefit many Quebecers and Canadians. Thank you.